It is a pleasure to now introduce our last plenary session of the day, entitled The Science of Trust, Restoring Confidence in Science and Public Health. In an era where misinformation can spread rapidly and skepticism towards science and public health initiatives poses significant challenges, understanding the roots of trust becomes paramount. Our panelists today will delve into strategies on how to rebuild trust, fostering transparent communication, and reinforcing the critical role of science in safeguarding public health. Our distinguished panelists are Emily Smith, Assistant Professor of Emergency Medicine and Assistant Research Professor in Global Health at the Duke Global Health Institute. And I will ask my esteemed guests to please make your way to the podium. And Professor David Lazer, University Distinguished Professor of Political Science and Computer Sciences at Northeastern University, and co-director of the NULab for Digital Humanities and Computational Sciences. Joining us virtually is Gitanji Gitaji, the Group Chief Executive Officer of Amref Health Africa. And finally, our moderator today is Matthew Baum, the Marvin Culp Professor of Global Communications and Professor of Public Policy at the Harvard Kennedy School. Anticipating an engaging dialogue, I yield the floor to Professor Baum to take it away. Thank you.
Thank you so much. We should have no trouble solving the problem of trust in science over the next 30 to 60 minutes. So we'll just start right in and fix the problem. Basically, the plan is for us to have a conversation for about a half hour, and then we'll open it up to you all for hopefully a broader conversation where we can pick up and extend some of these issues. So I want to start with a question for Professor Lazer. We seem to have arrived at a place of historically low public trust in science, scientists, and the scientific enterprise in general. And I'm wondering if you could say a little about how we got here, both in general terms, but also maybe more narrowly with respect to the role of misinformation and disinformation, as well as the related parallel problem of rising partisan polarization around trust in science almost across the board, and certainly in particular in the area of public health. I know it's a mouthful, but
I'll give my 10-word answer. Well, thank you, and thank you to the organizers for inviting me. Thank you to my fellow panelists. I think this is so very important. I do want to begin actually with just 1 minute digression, and then I'm going to dive into my answer, which is I've decided for every opening set of remarks when I'm in public to make a plea to leaders in universities, scientific institutions, medical institutions to figure out how to more effectively work together. We are in a moment of existential crisis. I'll go into the clinical diagnosis in a moment, but I think that the only way we survive this is if we figure out effective ways of working together, pooling our resources, mobilizing a public movement, supporting our institutions. So with that, I have longer remarks than that, but I'm going to keep it short and get to answering Matt's question. I'm going to just go through a set of points. I should note that because I'm so PowerPoint dependent, I actually have slides that I've posted online that have some of the descriptive statistics. So if you go to tinyurl.com/sciencetrust, it will take you to slides with some of the descriptive statistics that I'm talking about. So I begin just with a set of remarks that are obvious but crucial, which is that trust in science is essential. I mean, just trust in institution is essential for society to work. Right? I took the elevator up here. I trusted that slender string holding the elevator wasn't going to snap, and that I was going to plunge to my death. Many of you got in airplanes here. All that requires a degree of trust, and nowhere is trust more important than with respect to public health. And you, let's say, talk about vaccination, and getting vaccinated requires trust. And for many of us, it's not something we even think about. We did a survey where we asked people, why did you get vaccinated or not? Well, for the people who did not get vaccinated, the central word giant in the word graph was trust, like just what they wrote down. It's because if you don't have trust, it's like air. If you can see the air, there's a problem, right? And if you think about trust, it suggests that there's a problem. So moving from that essential point, I'll also note that one of the figures we have there looks at data we collected at the state level, trust at each state, and then subsequent mortality rate after vaccination. There was an incredibly strong correlation. It was incredibly predictive of vaccination status a year after we asked people in the summer of 2020 whether they were vaccinated a year later. The interesting thing, and there are bits of good news to say, trust in science is actually quite high relative to other institutions. It did go down after COVID. It went up and then it went down. I have a plot there of trust in science over the last 50 years in the US, and I'll admit my parochial perspective here. I'm focusing on US, but what happens in the US doesn't just stay in the US, as we've seen. That actually trust in science has been pretty flatlined for the last 50 years. Some of this depends on the kind of measure, but for the standards of general social science survey, it's been essentially flatlined with a spike up during COVID and then a drop back to baseline after COVID. So that's actually very good news that that science is one of the most trusted institutions in the U.S. Currently. But there are caveats to that. Well, first of all, there have been consistent demographic gaps in trust in science for the entire 50 years. It's been quite steady in terms of the demographics that have been less trusting of science, which includes people who are less educated, African Americans, people from rural areas, women, the more religious, and lower income people. Those demographics have been just systematically less trusting of science. And part of what we'd argue is that a lot of that has had to do with structural gaps between those groups and science. And indeed, we did some experiments where we said, do you trust the advice from the scientist? And we varied the demographic attributes of the scientists, and it turns out that demographic similarity was predictive of trust, but especially for underrepresented groups. And then the final point, and this really gets to the current political moment around political polarization, is the one place that has been very unstable in terms of trust in science has been partisanship. And what's interesting is that many of the groups that were less trusting of science, especially in terms of education, have polarized in terms of politics. So people with higher educations have shifted towards the Democratic Party, less education towards the Republican Party, and that was driving really since the aughts a partisan gap between Democrats and Republicans, where Democrats were more trusting of science than Republicans. Before that, Republicans were more trusting of science. And so that sort of switched in the aughts. And that little gap then became a chasm through COVID. And I think part of what happened was that gap created partisan opportunities on the Democratic side saying follow the science, and on the Republican side say don't trust public health, don't trust the science. And it was advantageous because it won the median activist in your party, right? In a period of political polarization, it becomes extremely important, more important to win the median partisan in your party than to win the median voter in the general electorate, and I can go more into that. But that has created basically an undercutting of trust in science among Republicans. It does create, and that has in part yielded the current moment. And I think again that there was a way in which COVID was very much an accelerant for that process, and that is, his life is path dependent. COVID came along at a very particular point of time. If it was 20 years ago, it would have happened, I think, unfolded very, very differently. But we are where we are, and I'm going to leave it there, and we can talk about the future, in a few minutes, I hope.
Okay, so let me pose question to Dr. Guttaghi. I'm looking at the screen where he's located. So let's narrow our focus a little bit and talk about the problem of health inequities. Could you talk with us a bit about the public health related lessons learned from Africa during the COVID pandemic in general, and in particular with respect to the role of misinformation in exacerbating the public health challenges in particular, as well as, if you would, measures being undertaken to combat the problem of misinformation?
Thank you very much, and thanks for having me, even virtually, since I couldn't make it in person. Africa has a very diverse population, countries. We have 53, 54 countries, depending on which ones you're counting. There are some that are not, controversial, not recognized or recognized. But anyway, more than 50 countries exist in the country in Africa, and they are not as united through the borders as those in Europe, for example. And therefore, you find that the dimensions of the response, misinformation response, also acceptance, were diverse across the continent. So there's no singular answer to that question in terms of Africa, but there are diverse responses country by country. I think the first thing I would like to say is that right off the pandemic, some countries were found with more experience of response to health threats than others. Uganda had dealt with several outbreaks of Ebola. DR Congo had done the same, and plus other outbreaks of Mpox that have been there since the 70s. Nigeria, Sierra Leone, Liberia had dealt with outbreaks. Others were not as experienced as those countries. And therefore, very early on, we started to see what happened based on this experience. Some countries actually pulled back on those experiences. And we saw, for example, that in some of these countries, community-based surveillance became the first thing they did. And obviously, because of the lesson that they had learned earlier, that community leadership in the response was the most important thing, because people trusted their neighbors. At community level, we have what we call community health workers in Africa. I'm sure they're also in other countries. But the ones that we have in Africa are not as professionalized as those you have in high-income countries. And therefore, they are basic, minimum, bare bones kind of information on health, but it's built not on huge levels of literacy and education, but it's built on these who are selected by their own communities have been found through these responses to be critically important in the responses, in surveillance, and in contact tracing. And those countries had already learned that. So they brought forth community leadership, community level leadership in the response. Regionally, we saw, for example, that WHO Afro, which is the regional WHO arm, and Africa CDC started to come on very early. Now, what we found was that WHO, whereas it was giving good technical information, was affected by the lack of trust that the populations had on WHO itself from Geneva. And this lack of trust in WHO itself, which flew all the way down to the regional body, was related to early attacks and in misinformation and attacks on WHO, which also said WHO was captured by certain individuals, captured by industry, and therefore was seen to be advancing a position that was pro-industry, not pro-people. And therefore, the institution of Africa Centers for Disease Control, whereas much weaker, much more not as endowed as WHO, received a lot more trust because it was seen as an African organization. So ownership became, a driver of empathy and authenticity. It was seen as it is ours, therefore we can trust it. And WHO, whereas it continued to work with countries, it really found that it could struggle. So organizations like ours, like Amref Health Africa, was working in multiple countries, emerged to fill the gap of trust. And because we work at community level and with governments, we were seen as a trusted source because we are non-governmental, we are not multilateral, we are not governmental, we are not private sector. So civil society came in to fill this gap of trust. But amidst all these things, I think the key lessons we learned, which I would like to share, is that trust was more useful where it existed before it was needed. There were studies done by Africa CDC, surveys on, for example, acceptance to response, wearing of masks, social distancing. And what was seen is that the rate of acceptance of these public health measures were higher where people originally trusted their governments, even before the pandemic. Ethiopia, for example, had high levels of trust, and therefore the government announcements and policy positions were more accepted and not questioned by the population. We saw the same with Rwanda because they trusted their governments highly. In areas where there were political division, there was a strong opposition that was fighting with governments, we saw less and less trust for governments, and we saw more and more attacks on the government policies and responses. So lesson number one was that trust was more useful where it existed before the pandemic. Therefore, trust in peacetime was very important in war. And this also related to the health system themselves, where people had tried to use the system before and they had not been served. There were high out-of-pocket expenses, there were no drugs in the hospitals. Before, in peacetime, people trusted the health system less during the response than countries where the health system was originally working. So here, saying that a good health system in peacetime is useful in war. The next thing is false narratives. These false narratives included being driven by key opinion leaders like religious leaders who had misinformation, and also community leaders who are not well informed. These were moving narratives like, for example, that vaccination was driving implantation of chips in people's skins for use by global forces, talking about creation of infertility through vaccination. So all these conspiracy theories came to affect the response and also affect the vaccination rates. But as I conclude, it's to say that there are things that worked. Where we found things working was, number one, as I said, where trust existed before. But number two is where the responses were people-centered, where actually the policies asked, what are people doing right now? Where are they? And therefore, you worked on the policies that were pro-people activities, not anti. We saw South Africa, the lockdowns became very controversial because they were anti the informal sector. People needed to go to work to earn because not everyone is formally employed. And we therefore, where the policies were not aligned to people's lives, they were opposed, and there was actually uprisings. So human-centeredness, even in vaccine provision, was successful. And where we had a big challenge was where countries did not open up their health centers over the weekend. And therefore, people did not receive vaccination because because the health centers were not open during the weekends where they are free. They are open when they are busy working and earning a living, a daily wage. So we saw lower vaccination rates where governments insisted people go to facilities on Monday to Friday. So I think I would like to first close there. But these were the key lessons that we learned. But I think finally, I would like to just mention here that trust did not develop organically for institutions. It was actually something that people already had for those institutions based on the way they had treated people and they had worked with people before. Over.
Thank you so much. Okay, a question for Dr. Smith. I was wondering if you might talk with us a little bit about the interconnectedness of trust in science, misinformation, and public health, both domestically and globally.
Sure. Maybe I can begin by saying why I'm here in the first place. Because my day job is at Duke. I'm a global health epidemiologist, looking at the intersection of poverty and children's health, war and conflict. Many of the children that come to the clinics where I work come with advanced cancer. So I work with St. Jude, or advanced surgical diseases that just cannot be fixed anymore because they waited too long. The reasons that they got there too late, though, most of the time is because the families had to make a decision between care for one child or feeding the rest. And so my work is to try to make that decision obsolete. So that's a long way. That has nothing to do with trust yet. COVID hit. I was in Texas at the time. I started a Facebook page called Friendly Neighbor Epidemiologist because I can be a little too friendly, a little chatty. I'm sorry if I sit by you on an airplane. But neighbor, because I love the story of the Good Samaritan. And most of us know this story. A man is hurt on the side of the road. Two people walk by, and those two people were religious leaders of the day that denoted power and privilege. But a Samaritan man stops, and he takes care of the man. Not only that, he takes him to a place to recover, and then he pays for all of it. And I've loved that story. To me, that is what epidemiology is a science of the Good Samaritan. That's why my book is named The Science of the Good Samaritan. So that's a long way to say I named friendly neighbor, because a lot of us epidemiologists knew something like what we were seeing in Wuhan was going to make us neighbor each other well, or required that, or the lack thereof, there would be repercussions. My global health equity work that I'd already done too, I work in Somaliland, in Burundi, and I knew if something like COVID hit there's no PPE. And when it actually hit, there was no PPE. So indeed, the disparities showed up. So I started the Friendly Neighbor Epidemiologist page thinking it was going to be for a couple of weeks, help people understand, flatten the curve, whatever. And we all know that didn't happen. I was in Texas. My husband is a pastor. We were at a very large evangelical church. So everything you saw on the news about Texas or what you don't want to see, I'm trying to be politically correct here, but everything you saw on certain news channels was my neighborhood in my church. And so when COVID became weirdly political, we all saw this. When George Floyd was murdered, when January 6th happened, I kept writing about it. This is a public health issue. This is an equity issue. This is a COVID issue, sure, but these are systemic and structural determinants that many of the people that I was writing to had never seen before. I wasn't noticing that it was going viral multiple times for good and bad ways. It would end up hitting 10 million people, and I continue to be in 160 countries with this platform. I've kept it up. But it was such an interesting experiment on developing trust with socially, on social media with a group of people. Mainly, I got in the door a lot because I was a pastor's wife. It's fine. I got in a lot because I was an epidemiologist. And then when you infused equity, and I was telling people about Somaliland for the first time and they'd never heard about that country, there's an opportunity there to do some education. Now we would move, leave jobs for lots of reasons. You can probably imagine why, when it's untenable to do what I'm doing and where we were at the time, which brings me to Duke. But this issue of trust in science, is certainly deep, but it is centered within the communities of where trust is lacking. And to have trusted messengers there, to be able to speak into whatever disadvantaged group or advantaged group. For mine, my own people were the ones that were the most hesitant against wearing a mask. And so for them to hear somebody say from the pulpit, actually, you can use scripture to say, this is loving your neighbors, is putting on a mask and getting a vaccine. So that's how I snuck into this forum, was through a roundabout way of being now a science communicator who's still doing global work.
Okay, great. Let me follow up with each of you and push a little bit on the issue of misinformation. So starting with David, in the story you told us at the outset, where does misinformation fit into this? As a cause, as an effect, as a peripheral player, as a main focal player? How would you characterize that problem?
I'd probably say as cause and effect. Mm-hmm. We could see, for example, that in the work that in the COVID States project, and this is Matt and I and a team of folks. So a large survey we were conducting, still conducting actually, although it's rebranded CHIP 50, that we found, that you could look at people who, again, early in the pandemic said they were trusting or distrusting, and it was highly predictive of future belief in misinformation. And it was related to where they got information, but it was also related to what information they were receptive to. So there's one way in which trust then affects where you get information and what you're going to receive. So in that sense, trust is causally antecedent to belief in misinformation. That said, the misinformation itself, one of the things that one of the targets of misinformation is to undermine trust. And so that's where, and we have other research predates this, but we're looking at how exposure to misinformation was in turn predictive of lower trust in certain institutions. And this was work with a collaborator, Katja Agnanova, and a number of others, well before the pandemic. But we were looking at, again, repeat respondents, exposure to misinformation, and how that was, again, predictive of a reduction in trust. So I think that there is sort of a cycle here, and some things are also based on life experience. And so another thing we could see is, sometimes the institutions we would like to trust are not trustworthy, right? I mean, if we think of the opioid crisis, a large chunk of that came through trusted institutions. It came through big pharma. It came through PCPs. And we could see, again, in our survey, a huge fraction of the country is being affected by the opioid crisis. We estimated, in terms of people who said, let's say it's in their immediate network, was roughly 1 in 5 people. And those people were less trusting. They were also less likely to be vaccinated. And you know what? They had some basis to be distrusting of the institutions, to be distrusting of pharmaceuticals, to be distrusting of doctors. And so this is, again, it's not just about misinformation causing distrust and so on. There are life experiences. There are obviously the experiences of particular groups, but there are also experiences of particular people and people in their networks. And we in the U.S. certainly we have had some reasons in the last generation that to say our trusted institutions really maybe shouldn't be so trusted at all. And so there's like that's sort of part of the whole equation, I think.
Okay, great, thank you. Dr. Gitahi, in our conversation a while back where we were talking about what we would focus on in this panel, you recounted a personal story regarding your experience with misinformation, in particular AI-related misinformation. And I was wondering if you'd mind sharing your experience with us and what lessons you drew from it.
Yeah, thank you very much. What I've found through all these journeys and my personal journey, which I'll share, is that human beings are by nature want the easy way out. So if you have a long-term disease, a chronic disease like diabetes and hypertension, whereas science tells you this is chronic, you'll take this medicine for life, misinformation will come and tell you, I can give you something that solves your problem in 2 weeks. It's the same with weight management. It's the same with all these challenges. It was the same with COVID vaccination, where people feared the injection and they were not sure because people said it will be painful, there will be fever. And then they were told, no, you don't need vaccination. Just take lemon water. It was easier to take lemon water than to actually get. So the ease of misinformation challenged science, because science is factual and science is difficult in terms of the solutions it gives. They are not instantaneous. So what I found myself is, because of the trust that I built during COVID, because I spoke a lot about vaccine injustice, I was on TV a lot, and people listened to me because I said earlier that we tended to close the gap, the trust gap that was there between government and private sector. So people trusted me. Now, people have taken my image of videos I'm speaking, like I'm speaking now, and then used artificial intelligence to alter the audio. And they will have me speaking about, for example, just as I'm speaking now, they'll alter the video and the audio, and I'll be saying that I've discovered a new medicine for hypertension, and if you buy it, you will actually be cured in 3 weeks. And people are buying $100 a month, such medication. Another video followed on diabetes, another one followed on erectile dysfunction. So they pick topics that are difficult for our people, for individuals, where science gives long-term solutions, and they give short-term solutions through AI change. So this threat of misinformation through AI is something that's going to make our work even more difficult, and that's going to complicate the trust in public health institutions even further. And therefore, there is actually a need for urgent, innovative resolution of AI use in ensuring that in saving people's lives and livelihoods as well.
Thank you very much. Okay, Dr. Smith, your turn. So you, as a self-described science communicator, what role has misinformation played in the efforts that you've been focused on with your work? How much of your time is devoted to combating the problem of misinformation? And if I can generalize from that and give you back a question that you suggested to me some time ago, how can you effectively talk about public health without losing your soul in the present environment?
Well, I asked that question because I kind of lost my soul. I mean, during COVID, it was so misinformation. It still is, but it was so daily and upfront. And so I wrote, daily post 500 times in a row, pretty much of during that time. And a lot of it was talking about some of the science coming out, especially when vaccines, helping people understand the safety and efficacy of it. But most of it was combating misinformation. You might have heard this. Let me actually tell you the truth. I say that question of how do you do that without losing your soul? Because most of us, I'm sure everybody else in this room feels the same way, just got burned out by always being on the defense like that with miscommunication. So now that we're back in the game, essentially, we all had to jump back in with the new administration. My approach to misinformation is a little different, where I'm still combating it, but I'm choosing carefully. Because what I've learned, if we think about measles right now, my hometown and where I went to undergrad is the hotspot of measles in New Mexico. And so Midland, Lubbock, Lovington, Hobbs, I mean, those are my family, essentially. I think one of the tactics of the new, maybe the new administration or maybe the Children's Health Defense or some of these that are the anti-vax, they're incredibly well coordinated and a lot of money. I think one of their tactics is to throw out a lot of misinformation at us and see if we'll just try to play whack-a-mole with it, and then we all get tired. So at least that's what I'm doing now, is I'm choosing carefully what to talk about. With measles, you bet I talked about vitamin A. And was it cod liver oil or one of those that, don't do it for your kids, guys. They will get very sick. But there are some misinformation that I'm just choosing not to talk about. At the same time, I'm talking about the truth. And if you can talk about the truth in a bigger umbrella about overall vaccine safety, that covers a lot of misinformation without you having to play whack-a-mole. So wisdom, yeah.
Yeah, I was tempted to quip, at least it's not bleach.
Oh, I know. Goodness gracious. Yes, sure.
The last question I want to pose to each of you, which you actually just sort of touched on, so maybe I'll focus more on our other two panelists, is where do we go from here? Any insights you can offer as to how we might go about restoring some of the lost trust in science and scientists?
Well, maybe I'll start. I don't have the answer. In part because
I promised within 30 minutes.
30 minutes. Well, we have 3 minutes. So in 3 minutes, again, the funny thing is, I don't think we've seen a plummeting trust in science. I do think we've seen, in some sense, it's the interplay in the U.S. The interplay between trust and partisanship, and I do think that's a huge problem because. It's a huge problem because it's a huge problem in the moment, but it also suggests that in the best case for the next generation, we'll go through feast and famine in terms of support for public health and science and medicine and so on. And that's not how to build institutions. You can't bring in grad students for 4 years and then cut off all funding for postdocs and et cetera, et cetera. And you can't fire everyone and then hire a bunch of people that those people move on. I do think that again, the good news is that there is actually a lot of latent goodwill towards science, even with a partisan gap. I think that we need, in the U.S., need to figure out, again, how to use that to mobilize support, because there is an interest everywhere. And I think that part of the question is, how do you build those networks? How do you build those bridges? And then the longer haul, again, is how do we build bridges? And we talk about diversity, equity, inclusion, and so on. These are the forbidden words right now. But they're the questions of, like, how do we build better bridges and more bridges? Because I also think that that at times we neglected socioeconomic gaps. At times we neglected outreach to rural areas, and that we need to do better. Which, I mean, unfortunately, I think in the short run we're going to do worse, a lot worse. But I think we need to figure out, how to build those bridges in adverse conditions. So, that's the best I got.
Okay, Dr. Gaddafi, your turn.
Yeah, I would like to say that the most important lesson for me is that science institutions, public health institutions, must focus on being community facing so that they can build trust every day. Their innovations, their policies. We talked about, for example, the innovations of vaccines. And we said, if the people who are working on vaccines do not consider that people are afraid of pain, that people do not want to go to the hospital to get their vaccine, they prefer to have it at the local pharmacy, that actually the whole community's social behavior must be part of science, meaning that then the people trust us, and therefore when they need us, they'll have built the trust. So we must build empathy, logic, and authenticity in our work as science practitioners, even when it's not needed, because then that means that we connect with communities de novo, even before we start the research. And I think even in research, we are told that we have to talk to communities way before, but we ignore these things because we are too focused on the hard science. The next thing is about public health institutions must remember that their core audiences are the people on the streets. Therefore, simplicity, connectedness, and people-centeredness are critical. That we must communicate simply. We must communicate in people's lingo. And that is when people then connect with us and say, I think I can believe you because you sound like me. And that is authenticity. You sound like me. But I think scientists and many of us are actually snobbish because we talk about just the facts, the policies, and believe them or not. So it is our turn now to think, how do we actually become community connected, simple connected, and people-centered, and communicate with empathy and authenticity so that the trust is built before it's needed.
Thank you. And I know I said I would give you a break, but I decided not to. So I'll give you the last word, Dr. Smith, and put the same question to you anyway, if you want to elaborate a little further on it even.
I think of it more from how do we do this on a normal Tuesday, again, while not losing our soul. And through the lens of equity and of neighboring. And, there's so much talk right now of we just need to meet in the middle, or we need to just come together. And this is bipartisan, just however you want to slice that. Historically, though, that middle has been biased and not the actual middle. So there's so much work to happen to bring the people who haven't had a microphone, like John Green said earlier. I loved that discussion, to let them have the microphone a whole lot more than those that have actually held it in terms of some power and privilege. So I think moving forward, if we can center, that's why I'm such a big advocate for neighboring. If we can center neighboring, to me, it helps diffuse tension in the room, even amongst differences, because neighboring means I'm going to neighbor you and you're going to neighbor me. It's a walking with people instead of over in a power dynamic. So I'm hoping we can have a posture of neighboring with one another. That does not mean that everybody gets a seat at the table and can say what they want. That does mean that you come with the focal point of equity in the middle.
Okay, thank you very much. At this point, I'd like to invite the audience to ask questions. If I could ask you to please identify yourself before your question. And we're going to be going back and forth between the folks in the room and the virtual audience as questions arise, but floor is open. They're going to bring you a mic.
Thank you. I just said I'm Megan Murray. I'm a professor in global health and an infectious disease epidemiologist. One of the things that those of us who are involved with COVID have been doing lately is sort of postmortems on what we did wrong. And one of the things that has come up fairly often is that we often, especially early on, overstated what we knew about the science to the point where we lost trust of people who, when we turned around and said, oh, actually, that's not right. We're going to change our minds on that. There's a number of books out on this, and I really think that was part of a sort of self-inflicted wound that we were more confident than we needed to be, or that the evidence supported. How do you think that contributed to the sense of lack of trust? And if so, how do we fix that now?
So whoever would like to field this?
Go ahead.
I'll give an initial answer. My instinct is to say yes. I mean, certainly undermine my trust, right? I mean, to an extent. I mean, and I'm generally trusting of science, but there's definitely things as someone who knows some things and doesn't know other things, and I'm trying to figure out, figure things out in the beginning, and leaving my mail sitting in the hallway for weeks and that kind of thing. It definitely, there were a whole list of things which really, I'm probably better informed than most, but I definitely felt like, whoa, I remember, there are a whole bunch, there's a long list of statements. And so I do think, on the one hand, that some of those things had to undermine trust, and that there was sort of overstatement of certainty, and there was a lot of the messiness of science, but then trying to somehow say, well, we're 51-49 sure about this, but if we just sort of say, we're a little sure about this, then no one's going to listen to us. It was, a lot of it was understandable, but I agree with your instinct. I have to say, it is harder to, it's harder to, we don't get to run RCTs on public communication. I mean, there are, I've run my survey experiments.
Sure we do.
Yes, we do, but we really don't, except for when I write the paper and say, yes, this is just like the real world. It really isn't. But my instinct is, so I'm not asserting this with scientific certainty, to be clear. Which is sort of ironic in the context, but it certainly felt like that to me. So,
Dr. Smith, Dr. Utagi.
I think it contributed a little bit. I don't think it was the main factor for trust. Also, maybe it's people didn't understand the scientific method as well, as we all needed to remember that this is an evolving situation. I think it was more of the distrust that was already happening in the communities, and it just being amplified. I also think politics just wreaked havoc. And I feel like politics was the bellwether for, the pivot point to this, rather than what scientists did wrong in communication, or if we would have been a little bit more hedged with our bets. Yeah. I just don't think that was the biggest contributor.
And I'll add, we sort of came back to baseline, but we didn't end up in a worse place, or not, maybe a little bit, but not clearly. And so, again, but again, the partisan split, and I do think that fits with exactly your story, which is the interpretation of all this messiness. There are two different worlds in terms of how to interpret what happened over the last 5 years. So,
Dr. Gatai, would you like to weigh in?
Yeah, I could just mention that, it's a really profound point because many of us will remember that WHO was really punished by its attackers on their position on masks. They used their efficacy earlier on. And that became a running issue that WHO did not know what they were doing. So I think the accuracy of information, certainty versus clarity, I think it's important in science to have clarity, but not, when there's no certainty, we should say there's no certainty. And I think that was one area that WHO was attacked for the use, for being certain about not using masks and then changing their position, whereas people saw that as dishonesty, whereas it was actually just scientific use of scientific facts. So there is some element there about whether, as an institution, how certain should you be about science that's not certain, and probably having clarity about what you know, what you don't know is probably a much better approach. But it's difficult. It's a very difficult question because you never know, because things evolve as well, and science evolves and facts evolve.
If I could actually break the rules of being just a moderator with no opinions and and follow up on Dr. Katawi's point, because we actually have a new case this year at the Kennedy School that all of our first-year master's students are taking that's focusing on the question of, the early decision to say that masks weren't needed through the lens of noble lie theory. So the idea that basically, and was it because of scientific uncertainty, or was it because first responders had urgent need of the supply that, we had inadequate supplies and that needed to be reserved for first responders, some combination of both? Turns out it's a really hard question when you actually push on it. What was the right thing to do? I think there's little doubt that that whole situation played an outsized role in decline in trust in science and COVID. So I completely agree, Dr. Katawi. But what would have been the right way to do it? Probably full disclosure. Although if there had been full disclosure, lots of people would have hoarded masks, and it would have thwarted the goal. I'm fairly confident in suggesting. Okay, other questions? Yes, ma'am.
Hi, I'm Shoshana. I'm an undergraduate student. My question was about, was kind of touched on before, about how science inherently changes, and how I feel like that is a big part of why science communication and building trust is so hard, because trying to communicate that when we get new facts, we're going to revise models and revise guidance is something that makes it sometimes feel like we're communicating not the truth, because it changes so rapidly. And if you have any input or thoughts on how to more effectively communicate the fact that that is just how science works, and the fact that the facts don't always stay the same.
I can start us off. And can I just say, you did a great job of saying that. You should be a science communicator. I think exactly what you just did, of things evolve. I mean, you said it so conversational. And your tone was you had nothing to prove. You were just asking a question. I think the way that you approach that is the way that we can build some trust with people. And just to say, gosh, science changes. And I think also when they know a scientist, like a lot of people that distrust vaccines knew me personally as a scientist. So I got a lot of, Emily, you would not lie about this, right? No, I wouldn't. Okay, maybe I'll go get the vaccine then. I think there's a way to develop science communication that way too, of me saying the data is still coming in, but early indications are, there are some code words and stuff, but you did a great job if you ever want to do that.
So could I push on you on just one thing you just said? You said, Emily, would you lie about that? And you said, no, I wouldn't. And why did they believe you?
Oh, because they know me. They know me in person. I mean, I'm not a person who's gonna lie. Yes.
Okay, so in other words, they trusted the messenger.
They trusted the messenger. Yeah. That's why it's incredibly important to have trusted messengers, it's not just trusted messengers. I mean, this is getting off topic, but when Dr. Fauci is up there or Dr. Collins and they are saying something, we don't have to know them to trust. I trust the science because I've got a history of trusting the science too. So I don't want to put the onus only on trusted messengers. I think it's a both and. So trusted messengers plus the leaders that we see talking.
Dr. Gatahi, Professor Lazer.
Yeah. This is, again, it's a difficult one because we had these challenges. We were asked by people when we appeared on TV, people said, are these vaccines safe for pregnant women? Then you could say, no, they're not approved. Or yes, it's approved. But when people said, actually the vaccines are causing increased menorrhagia or more bleeding, or they are interrupting people's menses, you had no data that was there, what do you do? And you want people to take vaccination. Do you say, yes, I think they are? Or do you say, we don't know? Or do you say they are not? So it's difficult. And at the end of the day, it's also about the intention of the communication. If the intention of the communication is information only, then you give the information that you have. And I think this is where the challenge came in, even with the mask thing. But when the intention of the information is to actually influence behavior, it becomes more complicated because then you have a bias towards the behavior you want. This is why it's so difficult to do science communication, because you wanted people to get vaccinated. So when they came and said, are you sure they are not interfering with my menses? You want the person to get vaccinated. So you're more likely to say, I doubt they are the ones causing the challenge. Therefore, I think you should get vaccinated versus maybe it's so maybe don't and wait. So I think the intention of the communication is in the middle of this very big question, and I don't think it's something that you can eliminate. But I think it's just to be, if you, as was said earlier, if you're authentic and empathetic, and people believe you're speaking because you have an interest in them, and that they can actually trust you to be like them, then I think that you'll have a much better chance at success in your communication than if you're just an institution that is where people don't connect and there's no connectedness. That's what I would say. But it's a complex question, again, just like the earlier one.
I would just say, yeah, that's a central question, and it's a tough one. And I think that intention issue is really central because first of all, you always have to simplify information. It's like, well, I did a literature review on this, and it's a little of this, a little of that, and of course it gets to the research design and RCTs, but RCTs have their own shortcomings and blah blah blah. That's bad science communication, right? And so it boils down to get vaccinated, right? But obviously that's a gross simplification, and I do think there's an interesting short run, long run trade-off also in communication, which is in the short run, you just want, say, the person to get vaccinated, say. But in the longer run, you want that trust in institutions. And if you sort of oversimplify it in problematic ways and that sort of surfaces, you lose trust in the long run. And that may be an essential tension. And this relates also to the masking thing, which was, well, in the short run, it's a noble lie, and we save masks for first responders. In the long run, we lose trust. And that's going to have lots of downstream negative consequences. The other thing I would note is I wish we would change, at least maybe this has changed and I've missed it, but I wish we would change how we teach science in K through 12. Because everybody who goes to educate, everybody gets trained in science in some fashion. Not everybody gets trained in political science, right? But everyone takes years of science, but it's often presented as a sort of a fixed set of facts. It's not really presented as a scientific method of this is what we thought. We saw crazy things 100 years ago, right? But 100 years ago, they weren't crazy, right? And we learned and we did better science, and the science itself, the method changes because there's a recursive nature to science, which isn't just about finding facts about the world, but finding out about how we find out about facts about the world. And it would be great to teach things we were wrong about, and how we discovered we were right. And that would be great if that was just integrated in K through 12 education, because there's a way in which that if people change their mindset about what science is, otherwise then you're just setting them up for disappointment. You're like, oh, don't we just know this and they're just fooling me? It's like, no, we didn't really know. We thought we had a informed inkling, right? But that doesn't that's not so that's not great either when you're trying to persuade people. But like I said, there is a sort of complexity in some of this short run, long run issue, and then the other issue is really how you get people to think about science. And people have a lot of years of science training, but it's not necessarily the way, honestly, that they should be, that they should be trained in K through 12, and that sets us up all for kind of disappointment when we don't meet that perfect standard of certainty.
I think you just had a great idea for a 8th or 9th grade textbook.
Yeah, yeah. Well, my spare time.
Yeah, well, you've got nothing else going on.
Could I add a comment? Could I add a comment, Michael?
Oh, you had a comment?
Oh, I'm sorry, I didn't see it. Sorry, apologies.
Hi, I'm Steve Schwartz. I'm with the Weiss Medical Foundation. Just a quick question. Based upon what we see happening with measles in the United States, can you relate that to the past few minutes of discussion that you folks have had?
Who would like to field this one? Nobody wants to go. Dr. GAVI, you want to take the first one?
Comment first, and then.
No, I would rather not take this one because the measles vaccination in Africa is actually very straightforward, and we don't have any controversies. It's almost universal.
Oh man!
Used to be here too. Who knew?
Yeah.
No, I would rather not take this. Here it's universal. We have 89% measles vaccination penetration in multiple countries in Africa. So that's actually I would rather leave that to those people who. Measles politics.
Would any of those who are actually suffering from this problem like to comment on it?
I mean, I could talk about it. I had mentioned before about the misinformation section of it, but what I'm seeing, sometimes we have vaccine that are, there's no getting to them. They are not going to take the vaccine. You have extremely hesitant. But then you've got this new group that are more vaccine questioning. So when I think of, some of my friends in Texas or New Mexico, they are not blatantly anti-vax at all. But the past couple of years, especially during COVID, a lot of their cohorts, they started having babies and they started asking each other, should we get this or not? For the first time, I never remembered asking that question with my kids. I just did it. And so those questions started like a little sneak attack into those communities. And then when measles happened, it's a whole new Wild West, literally quite out there. It's not the vaccine hesitant, it's the questioning ones now of how do you convince them to get it when all of their peers are kind of banding together and saying, well, I'm probably not going to get it until they're 4 or 5 or 6. That's an uphill battle. I actually don't know how to combat that, as well as, most of the blatant vaccine hesitancy. But it's also, if you look at this is probably not on certain news, but if you look on some stations, the Children's Health Defense, I know I've named them already, but that's RFK Jr.'s, shop. It's incredibly well organized. They are there in West Texas, in New Mexico right now. And if you look at what is coming out from that group in terms of scientific publications against the measles vaccine, they are organized because the BMC Peds just published something, then they hit the news with that. And so there's a game plan. So it's different than COVID. COVID, we were fighting whack-a-mole with misinformation. This time, it is a big behemoth of, I don't even know what to call it, that has, risen up. They've been there the whole time, but that is what we're up against now with measles.
The only thing I'd add to that is there's sort of an epidemiology of distrust that goes along with the epidemiology of disease. And so one thing is to state the obvious that there is sort of a clustering of distrust, which then creates a clustering of where disease can spread. And so that creates sort of pockets of vulnerability, of deep vulnerability in our communities for disease spread. But the other element is the I mean, it's interesting you're talking about, like, also with respect to children and so on, that we could see in our data, like that in particular, for example, that women in their 20s and 30s were actually systematically more hesitant about vaccination for themselves. But I think part of that may have had to do with around worries around pregnancy and so on. But that it seemed like there was that there were certain avenues for social influence, in particular around social media, that were very targeted to those populations. But we could really see how that stood out as compared to, it wasn't women who were older, it wasn't men. There was a lot more hesitation on vaccination among women, again, just of that age. And so, but like it also related then to things like use of Facebook and so on, where there are groups where if you're looking for information about vaccines, that's where the gravitational force will be. And we found evidence of that also around in terms of media use and so on, in terms of vaccine resistance and hesitance. So,
a question from the online audience?
Yeah, we have a few. I'll start with, in the new public space of social media, what really constitutes authority and trust? And what can social media platforms do to highlight science communication and convey accurate health info from the side of the media sources?
Well, I could jump into that a little bit, but I think that, and it's an interesting moment to ask that question. I think one thing that social media can do is identify credible sources of information. When you're searching for information, be more likely to surface those. Which is a little, there are different kinds of social media and so on. And so let's say if we think of Google and you're searching for health information, is Google taking you, to health authorities, real medical journals, and so on. And the same thing goes with YouTube. And indeed that there are a set of principles that YouTube and Google have signed onto in that regard. And so there are ways of like surfacing quality content that I think that some companies have supported. It's tougher when you're dealing with it's one thing when you're searching for information, and it's trickier when you're dealing with interpersonal communication, right? So would you say that that email should, if you get something from a relative as saying something that is anti-vaccine, would you say, oh, Gmail should just, send your aunt's email into spam? And I'd say, no. I mean, that would be deeply troubling. And so there are these really, it's not an easy issue. I mean, I think some elements are like clearer and other elements are really hard to figure out. And so, but I do think the other thing I'd say is it's actually really important for us to see what the platforms are doing in various ways. And I'd note that it's harder than ever to see what they're doing, because the data around what big tech platforms are doing has retreated, and our visibility into what big platforms are doing is far less now than it was just a couple of years ago. And so that would be the other. It's not entirely responsive, but it's sort of like, how do we shed light on what they are doing? Because I think that's also important, and that's harder than ever.
So I just want to say that I have one or two relatives, if their email was directed directly to spam, I'm not so sure I would feel badly about that, but...
There's settings. You can actually do that.
No, I know. Would you like to comment?
Sure. I will say now is very different than COVID, to answer this one, during the COVID time, because Facebook is now censoring all of my stuff. And if people want to share the Substack or blog, it's automatically you can't even post it. It's not even they have that blanket censor now. So it is a different time of sharing. I mean, social media is lovely when it is indeed social, when it's a social good. And maybe in its inception, it was like that. You get to connect with buddies you haven't seen forever and family members and show pictures. It has now turned, though, to not be that at all. Some of the platforms, and I mean, Facebook, Twitter for sure. I just got off most of social media completely, which I would advocate. If you're thinking about it, then just do it. You'll be happier. But TikTok is, there are some that are just going to be harder and harder to know what they're doing because things are ever evolving, always evolving. Security is also another issue for those of you who want to do science communication. We've received, like many science communicators, lots of threats, including at my house, against my children. And so if there has to be a level of accountability for that, and that is not on the platform because I have tried multiple times. And so just to keep that in mind, it's a very different social media than what it was several years ago.
Dr. Gataki?
Yeah. Two things I want to say. Maybe a quick reflection on the earlier conversation of communication, to also mention that communication comes with accountability and responsibility. I had an incident where, somebody brought someone who has clotting disorders. And I knew that if they don't get vaccinated, they are at risk of COVID and death. But if they get vaccinated, there is no real science as to whether the vaccines are going to affect, to make the clotting disorder a risk to their life. So I think even as we communicate, we must remember that we bear great responsibility, because you could actually communicate to someone and they take the action you recommend, and then they end up in harm. And when they end up in harm, it may be coincidental or not necessarily a consequence of your recommendation. And these are always at the back of our minds when we are advising people that there is accountability, there is responsibility, and life is complicated, and they could end up with harm and then end up saying it's because of the advice you give them. So that's always at the back of my mind. On this issue of misinformation and social media, I may have my own views about Elon Musk, but if there's one thing I'm very happy with X on, is community notes. Actually, there is AI that looks at information, and I wish that could be used on every post to say, this post, though it says this, science says the following, or WHO says this, and provides you with information for you to weigh your decision based on what has been posted. In my experience on the AI videos, AI altered audio videos that have been made of myself, I wish that Facebook had a way of using artificial intelligence to bookmark or to stamp fake videos where they actually check or say this may be AI altered or this may be this and that. I think that would be hugely useful and a worthwhile investment for those investing in social media. Thanks.
Thank you. Should we take one more from the online audience?
Sure. And then this one kind of is a little broader on science communication, in the sense that science is not really only about facts. It also involves ethical and political choices in the context of everything. So how can science communicators also engage people in those dialogues in a multidisciplinary sense?
Everybody says after you, nobody will speak. So,
I'm happy to.
Okay, please.
I'm friendly, right? Friendly neighbor. I'm always happy to chat in. I think, remind me of the question again.
So multidisciplinary science communication to those regarding like ethics, political choices, and much more. Yeah, I mean, for those of us who are here, we are probably geared intrinsically because of the public good and public health and global health and equity. And so when COVID hits, we automatically see it as a political issue as well as an equity one. My work right now with St. Jude, and you heard a little bit about that today, where the disparities between children dying in low-income countries versus high-income is one of the starkest that we have in global health right now. That's a policy issue, as a political issue, that's a colonial issue. I mean, I think as a science communicator, you can bring all of that in. And if you can do it through a story, in my book, the chapter that continues to get the most emails is the one I wrote about Dr. Khan, who passed away during Ebola.
He did not get the Z-map, but an American doctor who got it in a neighboring country during the 2 weeks after him did get it. Dr. Khan died, the American doctor did not. That is a structural violence, it's a political, it's a public health, it's an ethical issue. So if you can do it through storytelling and bring that out, then people, you can hook people a little bit more. But I say bring it in. If you can't help it, then bring it in, because everything is tuberculosis, right? Like we heard today. And so bring that in with the science communication.
If that's me, so I would say that the first thing that scientists need to realize is that not everyone is a communicator. The fact that you can crack the DNA code or create some fantastic innovation doesn't mean that you're a communicator. We have different skills, we have different gifts, we have different talents. I think finding those people who are able to connect with your audience, because communication is also about who you're talking to. If you're talking to a group of health workers, then it is okay to use a different approach than if you're talking to the general public. So I think recognizing those and then identifying who the right communicators are for the different audiences is probably the best approach, so that there's no one size fits all, but it's actually a diversified approach depending on the message, the audience, and what is the intended behavior. Then you may need to find different people or different ways of communicating, is what I would say, if I got the question right.
I guess I think it's a fascinating question, and it's interesting because some sciences and areas of knowledge endeavor have normative commitments and others do not, right? I mean, astronomy does not, I think, have deep normative commitments in the same sense that public health does, right? Public health isn't just like, we're figuring out how people die, I mean, it's like, how do we prevent people from dying, and what are the kinds of interventions? Like, how do you prevent mortality and suffering, right? That's it's a pretty basic normative goal, but is a normative goal in a way that's not the case with astronomy. But I think I'll go back to K through 12, but it would be great to think, to get people to think more broadly about what science is, and that science isn't just about creating a machine to generate facts. It is sometimes facts to change the world. There's a purpose of facts, and science communication is in part, how do you inform societal practices in ways that will make the world a better place? Fewer people dying, fewer people suffering, and so on. And I think it would be lovely if we integrated that better into science education more generally. So.
Okay, so this clock is befuddling me because it keeps resetting itself every time I think we're out of time. But looking at my actual watch, I think we probably don't have time for any more questions and need to, unfortunately, bring this to a close. So please join me in thanking our panelists for what was really a fascinating conversation. Thank you so much.
Yeah.